Are you ready, Nigeria? Ili Ends Health Society, in partnership with Dental Technologies Consult Limited, presents exclusive ends on dental implant training. Gain real-life knowledge for success in implantology. It involves online classes as well as in-person workshops. Procure the equipment and supplies you need to run a profitable implant practice. Facilitator, Dr. Uvoh Onoriobe.
I've heard so much about implants, but this was, let me say, this is a practice-defining lecture and experience. I would definitely recommend it to others to participate in the program next time.
For inquiries, contact Ego on +234-802 322-9290. For more info, visit www.8ends.org/courses.
Take it away, sir.
All right. Well, thanks for listening, everyone. I'm really happy to be here and just kind of talk a little bit about implants. As I said, my name is Dr. Luke Hearty. I am. Hold on one second. There we go. I am from Cleveland, Ohio. Just a little bit about me is that I graduated dental school in 2018. Also married my wife in that year. Her name's Alyssa, and this is our also beautiful child right here. This is Flossie. I completed my GPR residency in 2019 from the Cleveland VA Medical Center. And then I was commissioned to the U.S. Army in 2019, where I also met Dr. Uvoh. And so that's just a little bit about myself. So today I'm going to kind of talk about implants and the uncomplicated nature that it is. A lot of our knowledge is based around the fact that people tell us that implants are incredibly complicated. They need to be placed by specialists. They need to be placed by people who have big brains per se, but in reality, it is not that difficult of a process. The only thing that makes it difficult is when you start accepting things that are too difficult. That's when you start getting into trouble. So today I'm just going to try to break down the process of how I look at a case, 10 steps, going from, case selection all the way to putting in the crown, and how if you just stick to what you know and stick to basic principles, you're very much easily able to handle these sort of things. So let's get started here. So the first thing to do with any patient, first step, check that medical history. I'm asking myself 4 questions when it comes to an implant patient. First one being head and neck radiation. If they've got it, if they've had in the past for any sort of cancer thing, don't do any treatment, okay? You don't want to risk any sort of osteo, radionecrosis, or any necrosis, anything like that, okay? Second thing, if they are on blood thinners, you don't want them bleeding out on you. So you got to get clearance, make sure that we're able to control that. You don't like any surprises chair side day of. All right, next thing is chemotherapy. We're looking at bisphosphonate treatment here. We're looking at IV bisphosphonates and specifically, which could have a half-life of over 10 years. So in those situations, you want to be a little hesitant. If they've had a lot of bisphosphonate treatment, kick them off to someone else. Okay. You don't want to give yourself any headaches. And the last thing in the subject of headaches, medically compromised, compliant issue patients and patients that overall got bad attitudes and are grumpy people. You don't want to be messing around with them, because if they're grumpy at the beginning, they're going to be problems later on. So do yourself a favor, give those off to someone else. Okay. But like I said, if they start answering yes to some of these questions, you got to be hesitant about what you're doing. Okay. So once you got the medical history down, now you're actually going to look at them as, as the patients here. All right. Are they qualified for this? Did they have enough bone? I know you guys in your previous lectures, you talked about bone, you talked about different things that you're looking at and what would be a good candidate. So you got to make sure you got that. They got supporting dentition. If someone wants to replace number 9, but they don't got any posterior teeth, how long do you think that implant's going to last taking all the brunt of that chewing? Can they tolerate the procedure? As we said before, they got to be able to sit down for an hour to get this thing done. And then lastly is the whole mouth stable. If you're going to put an implant in some random tooth, but the tooth next to it's bombed out and it's going to need a root canal or get taken out within a year, sometimes patients, they also get a little grumpy when the fact that they pay all this money for an implant and they wind up losing the tooth next to it. So make sure that, we got everything taken care of. Now, some people, when they do come in, they just want one tooth replaced, you want to replace this tooth and everything else is going to hell. That's fine. As long as they're aware of everything, they're aware that those teeth are bad and you really reinforce that on them. So once you know if they're qualified, then you got to sell it on them. Okay. Yeah. Implants are expensive. Okay. I always believe at our practice, we make things affordable. We go about half the rate of most practices in our area. So people will come into our office just to get implants placed, and then they go away and we never see them again. And that's just because we don't have on the price. We make it low, and so we produce a lot. Over my career so far in these last couple of years, I've placed a couple hundred implants, and that's just because people, they want to be able to get things done at an affordable price, but also don't try to sell it too much. Okay. You start telling people it's going to fix all their problems and everything's going to be great and honky dory afterwards. And it's not, it's not. And so you got to also make sure you set some expectations. Okay. On the subject of that, you got to tell them what can go wrong after they know, like, okay, this is something we can do. What could be problems with this procedure? Complications, failures of integration, having to redo things because for some reason, the body rejects implants. Or you can have a situation like this where you got this implant here floating along in the sinus. Now that's more than a complication. Someone really messed up right there. But those type of things that they should know, that these are issues that can come with it. Okay. So then we move on to manage their expectations. So, they're on board with it. They know what can go wrong. Now you have to tell them, after everything gets done, what might not be their perfect result. All right. Main things are like food traps. As you guys know, an implant does not have the bony architecture around a tooth. Okay. So naturally, things will get stuck more underneath them, between the teeth. You can also lose contact over time. Teeth, we know, they shift. Implants, they don't really shift. They stay right exactly where they're at. So sometimes that can create more space, losing contact, creating more food traps. And lastly, aesthetic issues. As you can kind of see here, this person had a huge bony defect in there and someone stuck a couple implants right in there. Of course, it doesn't have like the root architecture, doesn't have the gingival, kind of flow over on top of that lower surface of it. So they look like big old hulky teeth there. Okay. So something else you kind of reinforce on. Remember, implants are they're not a replacement for teeth. They're a replacement for no teeth. Okay. Got to keep that in mind with the patients. All right. So now we're just going to kind of get into the procedure of it. So what I always like to kind of say is that we do have to pre-medicate. All right. So I always like to stick with amoxicillin, or if they're allergic to that, clindamycin, 1 hour before. And even more importantly, I believe in that is the Paradex or a hydrogen peroxide rinse, both prior to and after the procedure, sometimes up to about 2 weeks. These things have been shown in both case studies and systematic reviews to have an increase in success by 1% to 2%. So if you're dropping in an implant at 90%, success rate, good bone, nothing wrong with it, you can get a couple more percentage points by just pre-medicating and taking this rinse. Now, there was an oral surgeon in the past who told me that he doesn't pre-medicate for implants because in actuality, if you're putting a sterile implant into the body, you're not putting an infection into the body. So why are you pre-medicating? And I thought it was a good point, but again, I just go by the literature. I don't like to think a lot. And so the literature tells me you have more success. I'm going to do more success because I don't want to redo anything. I don't have time for that. All right. Now, so let's go into kind of the way when we start visualizing after we got that patient numbed up and we got them all pre-medicated and all that stuff. Now we're going to look at our flap here. Okay. So this is kind of a flap that I kind of like to do for a single implant. Usually it's going to be like an envelope sort of flap with a nice distal buccal release. This one here, they have this little kind of, this V-shaped flap, but they don't go into the papilla in this image here. And I've tried to do that before because you want to leave that papilla intact just for, some better aesthetics there. But for the most part, I wound up tearing some tissue sometimes when you start trying to retract that flap, and tearing tissue is a hell of a lot worse than cutting it. So I always recommend, just kind of taking it from, those embrasure line angles there and just kind of going down them. Flattening the crest of the bone is also very important too. You don't want to have a nice little triangle piece at the top where you're trying to put your implants. So, it leads to a couple problems. One of both, you might screw up your osteotomy. And two, when you start to actually place your implant, you might actually lose a little bit of bone at the top. Okay. Also, when you're starting to do those first couple of drills, make sure your assistant's double checking you're drilling to a safe depth. Okay. All these things are, they're very important, but definitely got to have a good flap, got to visualize the whole bone there as much as possible, at least half the distance on the buccal where you're trying to, place that implant, and at least a good portion of the lingual, but lingual flaps can kind of tough, So, but always got to have good visualization. All right, so we're just so the implant system that we use at our office is called Toman. So it's not one of the bigger implant systems, but they have been focused on only implants for a number of years. If you look at like some of the larger conglomerate groups like Zimmer and 3M or Nobel and Straumann, they've all got their own, like, you know, it's just one big company that owns all the little baby companies around it. Okay. But this one is very much implant focused, where Zimmer might also be looking at all sorts of medical kind of devices kind of focused there. What I like about Toman is that it's built for small brain dentists like myself. I honestly believe that Toman could be an implant system for dummies. They make it so easy to understand and flow compared to something like Zimmer that it doesn't take a lot of thought. With Toman here, they have 3.5 diameter is their smallest implant, and their biggest is 6. Now, to put in a 3.5 diameter implant, I only need 2 drills. I need this one right here, this 2.0 and this 2.8. That's it. I put in 2 drills and I can drop the implant in. They've got some other things here, like these contacts and element crystal things. But I don't bother with that. For me, less is more. I want to drill less and I want to put the implant in. The more times you go in there and you start screwing around with some, the more chance you have of messing it up. So we got our 2 drills here that would use to put in a 3.5. And as you keep going further, you know, if you're going to put in a 4 or 4.5 diameter, you go up 1 more. All right. Then we got our depth gauges that you would use, obviously, to take, you know, an x-ray, make sure that you got everything in the right spot. You're not putting it anywhere dumb. You know, we don't want to make sure that. But again, this is why I love this implant, this kit. If you got a 3.5 diameter, you got 2 drills. You got a 4 or 4.5, you got 3 drills. The exact same things. You want to put in a 5, you got 4 drills. They're not, you look at like Zimmer and these other ones, and they have these hard bone protocols. They got soft bone protocols. I don't have time to think about that stuff. I got, you know, when you're placing an implant, you're not just doing that. You got a patient over in cleanings that you have to do checks on. You got, you know, other things that are on your mind. So keeping it simple is always better. Okay. So that's my advice. And then we got the, you know, torque wrench that you would use to put the implant in. And they also have guided placement options. But my thought is if I'm not confident enough to place this implant without a guide, then this implant is likely going to be too complicated for me. I'm not going to sit here and charge the patients all this extra money just to do guided, when we can just get when again, it's getting too complicated. Push it off to a surgeon. Don't overthink things. Okay. All right. So then we're just going to look at the placement itself. What I always kind of like to look for is at least 1 millimeter of bone all the way around the implant. Preferably, I like to have at least 1.5 millimeters around the crest. That usually would tell me that I have, you know, more thick bone as we go down the implant. But you definitely want to at least try to cover up the collar if possible. So you got the collars right here. You want to have those at least at bone level, because as soon as you place that thing in 6 months to a year, you're going to lose 1 millimeter to 1.5 millimeters of bone. So if you've already got a thread exposed, when you put the implant in, you're going to have another 1.5 threads exposed by the time you're ready to restore. And so you don't really want to have that. Also, after you're done with your osteotomy, make sure you rinse it with saline. You got to get all that crap out of there, anything that's bad. And then, of course, torquing it. So now there's always this thing that says you got to have torque when you put it in. I've put in a lot of implants into some soft maxillary bone, and they get primary stability, and they don't always need to have the torque values. Okay. They wind up, some of those were some of my best implants, and they're still in 4 years later. We take our x-ray, everything's perfect. Okay. So primary stability and torque is necessary, but if you can't get torque, at least have primary stability. Okay. So after you place the implant, I always like to place a cover screw afterwards. Some dentists, they like to place, healing collar, something to push the gingiva aside so the gingiva has time to heal around that over those few months that it's sitting in there. I don't like that. I don't trust patients. I think they're all going home and chewing on rocks and playing with that healing, abutment. So I don't deal with that. We just like that. I like to have that cover screw in there, and I want that thing to be buried underneath that tissue. Again, I would sacrifice more work later on with the impression than having a chance of it actually failing and redoing the whole dang process. I don't like doing that. All right. Now, after you put in the implant, follow up with them on the phone. Got to show them that you care. Okay. That's always what I like to do. And then have a 2-week follow-up where you'll kind of go over, the next steps with the patient and choose an abutment. So on to the next step, actually choosing an abutment. I like to choose the tallest, biggest abutment I can get. And I let the lab trim it down. So after I get my impression, I tell the lab tech, go ahead, trim this down to whatever you need it to be, and I'll use that. And a lot of times that's like a custom abutment without paying for a custom abutment. Generally for an anterior, I like to have like a short collar. So a short collar is like this right here, right? It's just a little collar. So the implant would come about right here, and then the edge of the crown sits about right there. A longer collar is this right here. So the implant sits about right there, and then the crown sits up here. So for an anterior tooth, we generally let go of the short collar because over time, that bone's going to recede. So is that gingiva. And so you're going to have some gray showing, and people don't like seeing all that gray. They want to have a nice, pretty tooth. Now, unless you bury that sucker really into some bone, in which case you may want to go with a long collar, because just like with a crown, you got to have that biologic width. If that crown's coming down and it's right at bone level, man, it can really piss off those gums in that bone. Okay. For a short, for a posterior tooth, I'm a little bit less concerned about the collar. Preferably, most people, when I put in posterior ones, they just want to have a tooth filled, so all the chips that they're eating don't start stabbing their gums. So they're more or less happy with just getting the crown there. But again, you're looking at interocclusal distance, but most importantly, just get the biggest, longest one you can, because just like with a normal tooth, you want to have a nice tall abutment, and you want to do the same thing with your implant. All right, so step 9, the impression. Buccal keratinized tissue. I've been burned on the past where I haven't left that buccal keratinized tissue, or I placed the implant too buccally where I lost all that. And I wound up seeing a lot of gum infections kind of happen around implants. It stinks when that happens, and you beat yourself up about it. And it doesn't always ruin the implant itself, but it makes it annoying for the patient and something they continue to complain about. So always make sure you try to preserve that as much as possible. If it's an anterior tooth and that cover screw is buried, this is the time when you would go ahead and put that gingival healing collar on it to start pushing that tissue away, and you come back in a couple of weeks and get the actual impression. Something also to consider is that you got to look at the undercuts too. Before you go and take your impression, if you've got a huge undercut, this image isn't very good, but if you got like a big undercut under especially like a posterior tooth by like a molar or a premolar where it's got some gum recession and some bone recession there, by trimming it down on those sides there actually can give you a better path to draw more contact and also fill up those black triangles that are right in between the teeth there. So it gives them not only a better aesthetic look, but also less of a food trap. And I can't tell you how many times I've seen people come in, they just complain about their food traps underneath their implant. It's if you can fix it, guys, fix it. Okay. All right, step 10, no delivery, our last step here. All right, so for anterior teeth, most of the time, you're not going to be able to do a screw retained. It's going to have to be, you put the implant in, you torque it down, and then you cement a regular crown on it, just like you would with any other normal tooth, okay? Now, for posterior teeth, I actually like to do the exact same thing, but I tell the lab to leave an access hole inside the tooth where I can cement it. So this way, I can put my abutment in, torque it down, take my x-ray, make sure that abutment is all the way where it should be. And then it's just like putting on a normal crown. You sit there, you check the interproximals, you make sure everything's seated. And that usually works out pretty good for me. The other way of doing it is to do it completely screw retained, which means that the lab would cement the crown to the abutment, and all you do is just screw that sucker in there. The only thing I don't like about doing that is that I've had it before where as I'm sitting there, I'm screwing it down, and all of a sudden I get a lot of resistance. Then all of a sudden I get, less resistance, and then it's torqued in. The thing is it gets stuck underneath another tooth. So then when you try to go in there and try to floss it, floss ain't getting through. And then you try to take it off, and the sucker's not coming off. And then you wind up having to drill out the contact just to get the implant crown out because you couldn't floss through it. So that's why I don't like doing that. It is quicker to do a screw retained completely, but I had a bad experience once, and so I don't do it again. I got a small brain. I like things that work, and it works in my hand just doing cement retain for the back, just with an access hole for implant retrieval in the future. Okay. Always make sure you have light occlusion too, because you just don't want anything to to hit that implant too hard. It doesn't have the same give that normal teeth have. sometimes people get a little bit concerned about if it has no contact with the tooth above it. I have found that over the last couple of years, that teeth that I've taken out of contact, they come back a year later or 6 months later, and I just take a look at the occlusion really quick, just sitting in the cleaning chair, and all of a sudden they're hitting the crap out of that thing. So teeth definitely will drift. So don't be sending your crowns back just because they're just a little bit out of occlusion. Okay. All right. Last part of the thing here. I'm just going to just kind of a couple extra tips before I just look at a couple cases. First one, don't bury your implants too much. That bone, especially if you graft it, can grow over that thing. And then, good luck finding it. You'll be sitting there searching for 15 minutes, drilling away bone around your implant, just trying to find the damn screw. So just keep that in mind too. All right. And also don't be afraid of immediate implants. I'm not going to lie. Anterior placement of implants is the hardest thing, trying to find that bony architecture. But when you take out a nice, easy front tooth, that osteotomy is already drilled. You need to upright it just a little bit, sink it a little bit deeper. But I'll be honest, these ones are the easiest things in the book for me. All you have to do is get that tooth out cleanly, and that implant can come in real nice. You go in there, you put it in just a couple millimeters deeper than the edge of the root apex right there, and you can get yourself a really nice implant. Graft around it afterwards, and it really does come in nice. Those have been my favorite ones. I've actually had the most success with them, and they're easy. They're really simple. So don't be afraid of anterior immediate implants. It really does make it easy to have that socket already prepared. Okay. Another thing is that if after you put in your implant crown, if the tooth next to it has no contact, but it's got a filling next to it, instead of redoing the implant crown and sending it back and getting a new one, and sometimes it's a little bit out of your control because there could have been a crappy filling on the tooth next to it, just has a small contact area. You could always just redo the filling on the tooth next to it, and voila, there you go. You got contact back. Okay, just something to think about. Just a couple more tips is that a question I always ask myself is this too difficult to me? If I have to ask myself that question, it's already too difficult. Don't even bother doing it. A headache is never worth it. And as I kind of said, I don't like to think a lot. I like things that are easy. And if it seems too difficult, it's just too difficult. Don't worry about it. All right. If you think that, if you feel that the ridge is too thin, you have no primary stability, I just abandon it. You can't put in an implant that's moving in there. I find this a lot in areas of like 7 and 10 where you look at it clinically and you're like, oh, this has got a nice fat ridge. It's going to be easy. You get in there and it's just garbage. So something to kind of think about. There's no point in trying to be a hero. Just graft it, come back, do something else with it. Okay. There's always a worry about sinuses too. It's okay if you go into the sinus a little bit. Is it ideal? No, but plenty of implant success by just going to the sinus by a millimeter or two. Obviously, you don't want to drop that one sucker in there like that one picture I had up earlier where it was, floating around their sinus up by their eyeball. So you don't want that, but a millimeter or two is okay as long as you got at least 4 millimeters of good bone that's holding it. Okay, that's going to give you a quite a bit of success. Okay, and last thing is I do not block for any of my implants. Especially, when we were looking at like lower molar area, if you just infiltrate, that will give all the bone it needs to be anesthetized. What I've actually found is that as you're going in from if you IA block it, you don't know if you're going to hit that IA nerve, that mental nerve. You have no idea, right? Because it's all numb. If you just infiltrate, as you get closer to that IA nerve or the mental nerve, some might feel it a little bit. They feel it, you just back off. Okay, that's all you do. But it's just a little trick to keep yourself out of trouble. Again, it's okay if you go into the sinus a little bit. It's okay, and just don't block for lower implants, and that will keep you out of trouble, guys. Okay, that's all you gotta do. And I'm just trying not to get sued. That's always my goal. All right, so we got just a couple cases here. A couple immediate ones too that I thought were kind of fun. So this guy came in. He's just looking to get anterior or posterior implants. Okay, so we're gonna have a very similar situation to our right side as we do our left here. So we got a number like I think it's 12 and 14 here. So obviously big PRLs. This one had an infection on it. We sit here, plucked out the teeth. Obviously not enough room for implants here. He's got posterior. Opposing dentition down here somewhere too. We put them in again. This socket's already done. It makes it really easy to find where you got to go. The infection ends about right here, probably about 2 millimeters beyond. So I put that thing about 4 millimeters beyond. I'm way up in here, okay? Lined up another one next to it, got a good result. Cortical plate right here, so it's good, hard, dense bone. Didn't have to go into it. It's gonna give us a good result here in another month. We go to his other side, and I did literally the exact same thing. Almost, I think, the exact same corresponding teeth. So we're probably looking at number 3 here, and this is number 5 here. Again, so plucked them out. Nice osteotomy, almost prepared right there. Took my X-ray, realized this guy was going off and a little bit shooting at a little bit of la la land there. I don't know what I was thinking on that first drill, but corrected it with the second drill, and we got a good result right here. Grafted up around it. Those are going to be 2 nice implants there. It looks like I'm a little close to this canine right here, but if you look at it in the mouth, this is just the angle of the X-ray. Ain't nothing there. All right, another case here is this number 30 implant. Immediate implant. So we got another big infection in this tooth. So this sucker's got to come out of there. All right. So she's also got an upper denture at this point too. Okay. All right. And so what I do is after you got to tease these teeth out. If you start wrecking the teeth coming out, you're not going to be able to place an immediate implant. So also going back here, my eye ear nerve is way down here. Okay. So I got a few millimeters to play with right there. All right. So usually I want to place these things not in this distal socket, but in the mesial socket. Okay, that's going to reduce the amount of food trap right here. But as you can see right here, that's a big ass infection. Excuse my language. But so obviously I want to dodge that. All right, so I put that thing right in the distal socket there. Okay, so I put in the biggest, fattest implant I could, given all my buccal width that I needed, and grafted everything around it. And we'll see here again in another month how that one came out. I don't have any updated cases recently. I didn't get any picture or anything like that for it. So, but another good one right there. Now there is some surgeons say that actually the ideal thing to do here would be to place it right in the middle. So what some of these surgeons do is they'll actually, while the tooth is still in, drill an implant osteotomy right into the middle of the tooth. That gives it so it's right in the middle. It's ideal spot, not going to be too close to this tooth, not going to be too far away. But then that makes it really complicated for me to get out. And again, at that point, I'm thinking too much about trying to place an implant and extract a tooth while I'm drilling an osteotomy. No, I'm not thinking about that. It's too much work. Okay. All right. Here's another one. We have a 10 and 14 failed implant. You can kind of see the bone right up here, kind of shoots up a little bit right there. And then this one, actually, the implant abutment actually broke off inside the tooth. So this thing's actually just kind of dangling right here. So this is an image of before. So this one, we extracted it. We, I just drilled around in the buccal, plucked that sucker out of there. It's like you're plucking out a tooth. And this one, the patient pulled out himself. So as you can see, the dentist who placed it, these have only been in there for, I think it was like 2 years or something at this point. So as you can see, this implant was placed okay. This one looks okay, but this one was just not even close. You can tell that he didn't flap that one. He just kind of went blindly in, tissue punched it, and then boom, couldn't see where it was going. So after we had that thing out, sit there, didn't go into the sinus, just put it right up against the edge of it. Nice hard bone. And haven't seen him back in a couple of years now. All right, last case here. So we're just looking to do an overdenture. So this one we just kind of took in two parts. I'm not going to sit here and start doing immediate implants in this guy. We took them all out and then let everything heal over. Okay. Otherwise, we have nice depth of bone, a lot of depth away from the IA nerve, good depth up here too, all along the maxilla. So this one would give me a little bit of trouble, and I made a little mistake here. All right. So when we were putting this one in, he started to feel it as I'm putting in this number 3 implant. So as I would sit there and torque it down to the edge, it was about right up here. And then he would say, I feel it. So I backed off. I gave him a little more anesthetic, tried it again. He still felt it. At that point, I said, all right, I'm not going to sit here and put in an implant that could be painful. It's going to be right on the sinus border. I just brought it out 1.5 millimeters, and it should be fine. However, if you look at this, it comes about right here, which means that I have maybe a thread exposed, maybe 1.5 threads on the distal. What I should have done was taken out this implant and put in a shorter one. But, I shouldn't have done that, but this is still going to be okay. It's still working. It's been in there for 2 years now. You can't even see it. His gums completely overhealed it. But again, I had at least a thread exposed there. So I should have put in a smaller implant. So remember, you can always do that. If you start putting in your last implant and all of a sudden you realize you see a thread, just back it out and do it again. Put in a shorter one. And the other one is one right down here. I did not flap the mandible. All right. And after this, I always did. So on the his bone was really, really jagged, but I took a nice big tissue punch. I could see that I had bone all the way around this tooth, but after 4 months, it failed, which is right here. All right. As I was sitting there, torquing in the abutment, he started saying, ouch. And all of a sudden it wiggled and came out. I don't know why it failed. I had good primary stability. I thought I had bone all the way around, but there could have been a bone defect somewhere that I couldn't see because I didn't flap it. And it's one of my regrets right there, but I paid for it because I had to go back and I had to do it again. So from that moment on, I said, nope, everyone gets flat from now. If I'm going to put these things in, I'm going to make sure that I have good visualization the whole time. Okay. But that's about it, guys. I appreciate y'all listening. I know I ramble a lot. I talk fast sometimes, and my language, I use some foul words every now and then, but I really appreciate you guys all listening to me, and it was my pleasure to be here.
Thank you so much. Thank you so much. Do we have any questions? Do you have any questions?
Yes, sir.
Yeah, go ahead.
Okay. Thank you so much for the wonderful lecture, sir. I have a question in respect to the posterior immediate implant replacement. He made mention of placing it distally, that his own pattern is placing it distally, and some surgeons say that they can actually place it in between the distal and the mesial aspects of the tooth.
Yes.
Okay. My question is, since there is space already in between in the mesial and the distal sockets, placing it in the middle, would it make the implant to be unstable? I don't know whether you get my question.
Whether you think it'd be more stable putting it in the middle between the two, or between the two sockets, is that correct?
I think placing it on the distal aspect or the mesial should be more stable instead of placing it in the middle. I don't know.
Yeah. Okay. So what they were basically trying to say is that it's more ideal for if you had an ideal bite where someone's biting down, and as they're closing, you want to have that implant right in the middle, so there's not much side to side motion. So if the opposing tooth comes right here with the cusp, if this implant's coming right here, that means there's more of a tilt, more of a rock when they bite down. But what they're saying with that the interseptal bone, if you put it in the interseptal bone right here, this is all good bone. It's not manipulated. It's not, you didn't just take out a tooth from that area. So they say that bone's going to have good blood supply. It's going to heal well. It's going to be more ideal for bone. And that way, when you pack your bone graft all around it, it's just going to make that bone even stronger. It's just going to regrow bone around it. So right when you're putting it into a socket, that bone, if you think about it, when you're sitting there torquing out that tooth, you're putting little cracks all in that alveolar bone. So they say that's why it's not as good. So they say in doing this technique where basically you take off, like this is a situation, you pop off this crown here and you literally start drilling an osteotomy right in between the two teeth here. Okay. What that's also doing is loosening up these two roots at the same time. Then as soon as you got your last osteotomy drilled it out, you pluck out the two roots. And then when you look inside, there should be a perfect hole ready for your implant. And they say that is the more ideal bone. Stability wise, I think as long as they got good bone all the way around it, it'll be stable. You ain't gonna have no problems, but it's really just a matter of preference. I think that's more the bigger brain way to do it, is to try to put it in the middle, but that's too difficult for me. I don't like thinking that much.
What of the restoration? Because you have a lot of space now between where you placed it and where the actual crown is going to go.
Yeah. So that's going to be a problem for me when this thing finally ends up there, right? Because again, you want to have either the mesial or right in the middle. So yeah, you're absolutely right. It's there could potentially be a food trap. What I'm really going to try to do with this one is, after all that tissue is really healed, and I might wait 5 or 6 months to make sure that tissue and that where that bone graft is completely where it needs to be. I want that tissue to be non-moving. Then when you go and you put in that crown, they're going to make it so that it fits perfectly in this area. If you can actually see here, it's actually kind of nice that this crown's kind of flat right there, because that means when I go to put mine in,
will it be a bigger crown in terms of?
No, I think it'll be the same type of crown. I think you can't, because of course you can't make the crown.
The access
big,
will be more distal. Yeah,
it'll be on the distal. So the mesial is going to look just like a normal crown, but yeah, I'm more concerned about a food trap than anything with that one.
Okay. If we have more questions, please go ahead and ask. I'm going to thank you, Luke. This has been wonderful. Dr. Luke is my weekend. We meet on some weekends.
Yeah, I'd say about once a month, huh?
So it's been and he has given, like, in terms of what he does in his practice, and he places a lot of implants on a daily basis, on a weekly basis, and he has got good outcomes. So I decided to invite him here today. Obviously, there's a question here about whether you put some bone graft. Yes, most of what he has done, you just want to put some bone to make sure there are no threads, or if you have any space in between, and cover it up. Yeah. Okay.
Absolutely.
Thank you so much, Luke. It has been fantastic. This is recorded, so obviously Dr. Luke speaks as fast as I do, so you probably want to listen to this video over and over again.
Yeah.
I'm going to place it on the YouTube site. Thank you so much, Dr. Luke. It's been wonderful having you with us today.
Of course. Thank you.
All right. Okay. All right. Thank you. I'm
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator